Hello, everybody. I'm Juan Valle. I'm a Professor of Medical Oncology at the University of Manchester and the Christie. It's my pleasure to have a quick discussion today about the clinical implications of molecular determination of cholangiocarcinoma. The world has really changed over the past few years. Traditionally, we've been using the tools of surgery, chemotherapy, and radiotherapy, but we've also learned over the past few years that through molecular testing, we're able to identify subgroups of patients who have a molecular alteration for whom we may be able to have a treatment to match. Now, this isn't just a theory. A number of studies have now shown for certain alterations and that giving specific treatments are able to control the cancer, even induce shrinkage and reduction in size of the cancer for a durable amount of period of time, associated with acceptable side effects and acceptable or improved quality of life. So it's important that we know the molecular alterations that are present in anybody's individual cholangiocarcinoma, and that currently involves taking a biopsy of the tumor, which we can then test in a laboratory and look for some of the genetic and other alterations by running very specific panels looking for these specific alterations. What molecular characteristics are we looking for? Well, at the moment, we'd be very keen to identify if somebody has an FGFR2 fusion, that's fibroblast growth factor receptor 2. And that's because we now have a treatment that's available in the US and in Europe that we can use for patients with those specific fusions. That happens in about 10 to 15% of patients with cholangiocarcinoma. A similar percentage also have an IDH1 mutation, isocitrate dehydrogenase mutation. But we're also looking for other subgroups that we can potentially treat. Patients with amplification of the HER2 receptor, patients with mutations in BRAF V600E, so it's a very specific mutation of BRAF, as well as patients with NTRK fusions. Finally, the other thing we look for is for any signals that might tell us whether individual patients might be suitable for immunotherapy. Currently, immunotherapy remains investigational in cholangiocarcinoma, but certainly if we were to identify patients with tumors and microsatellite instability signature, we would then want to think about immunotherapy for those patients. So all of this is really telling us that unless we undertake these molecular profile tests, we're not going to know if patients have individual alterations because they won't show up on any scan. Nothing in the history will tell us. So we do have to do the molecular profiling test to be able to give these treatments. And we hope that that will then control the cancer, improve quality of life for patients, and live better lives.